Lung cancer is particularly close to many people's heart. It's unusual to meet a person that hasn't had at least one degree of connection with that, a family member or a good friend. It is the most common killer cancer, if you will. It kills more people than any other cancer. The irony of it is that it's detected much earlier than often it is. Historically, about 50% of lung cancers were picked up by accident, a CAT scan that was obtained for a car accident or chest pain. Beginning in 2012, we intentionally began to screen at-risk populations. The risk population that was defined was age 50 to 79. If you'd smoked greater than 20 pack years, and the way you calculate a pack year is pretty easy. It's the number of packs per day for the years you've smoked. And then finally, if you've quit, you quit less than 15 years ago. If that risk stratification is applied and folks are screened appropriately, there's a 25 to 30% reduction in mortality from lung cancer, which is huge. When you look at the three major screening tests, lung cancer screening, mammography, or colonoscopy, the most efficacious, the most effective is lung cancer screening. It takes about 800 colonoscopies to save a life. It takes about 1,200 mammographies. It only takes about 350 lung cancer screening tests to detect and save one cancer life. I mean, this is a CAT scan. This isn't a colonoscopy. This isn't a mammogram. It is a non-invasive imaging study that is very efficacious when appropriately applied. Historically, folks have waited until something was wrong. It hurt, it didn't work right, it didn't feel good before you pursued care. Even when you're without symptoms, applying this screening test to an at-risk population leads to detection of the disease when it can be treated much more effectively. It's designed to pick it up when it's early, when it's small, and when survival is tremendously better than it's picked up when you're having a cough or chest pain or some other symptom. If you look at our population here at TriHealth, the people that enter the lung cancer program who have not been screened, their 5-year survival is about 21%. If you look at the people that have entered through the portal of lung cancer screening, it's about 85%. Huge, huge difference. I mean, without question. Detected early, it's a minimally invasive procedure with a 1 to 2 day hospital stay, or other forms of precision medicine or radiation therapy or so on. If you scan 100 people in this area, 40 to 50 of them will have a nodule. Only 3 to 4 of those will be cancer. So a big part of the process attached to lung cancer screening is you have to have an infrastructure. You have to have people around it that can figure out which of those 3 or 4 need to be taken seriously and which of them can be monitored. The lung program here at TriHealth is designed to meet patients where they are. There are 44 providers involved in our lung cancer program and all the support staff, so it's a large number of people. And the goal of that group is pretty simple: early detection and appropriate therapy for lung cancer. And we say appropriate therapy, mean personalized. We spend a lot of time and energy making sure that what we're offering to patients is entirely appropriate to them. There are 4 different therapies for lung cancer: surgery, radiation therapy, chemotherapy, and immunotherapy. Which of those 4 therapies or in what combination they're applied really depends on the person, their functional state, their stage of their disease, and the overall anticipated effects of the therapy. Even in the best of hands, only 12 to 15% of at-risk folks are screened, which is crazy. That'd be like saying of all the women who are qualified for mammography, only 12 to 15% are screened. And so we work very hard in patient education, physician education, community education to let people know, hey, this is out there. Because you can imagine the impact on the overall health of the community if more folks took advantage of the screening.